Hey, good afternoon, everybody. Thank you for joining us. So I want to welcome you to this afternoon session at PSHSA's The Workplace Reimagined Virtual Conference. Excuse me for a moment. I try to mute the chimes. Sometimes it works, sometimes it doesn't. We'll have to deal with the chime sounds until I'm done. I just want to do a brief intro for you all here, and then we'll pass it over to our presenter. So my name is Ricky Terrio, and I am the Manager of Client Experience and Operations here at PSHSA. And I'm pleased to welcome you to this session. It's called Science and Sensibilities, Pandemic Lessons to Prevent a Bleak Midwinter. Presented by Dr. Kevin Hedges, an occupational hygienist at Occupational Health Clinics for Ontario Workers, or OHCOW. Before we begin, I want to mention that there will be an opportunity to answer questions following the presentation, so please feel free to enter your questions in the chat, and we will select some to ask from there. The session reflects on lessons and solutions from Science and Sensibilities as experienced by thousands of workers during the first wave. Dr. Hedges has 30 years of experience as an occupational hygienist and has been at the Occupational Health Clinics for Ontario Workers since 2016. His career as an occupational hygienist commenced in 1990 after working as an industrial chemist for 10 years prior. The first 10 years of his career as an occupational hygienist was laboratory-based, with BHP Environmental Health Laboratory, followed by a stint with Merck Sharp and Dome, MSD, and was a member of the Merck International Exposure Assessment Team, where Dr. Hedges was instrumental in improving the risk assessment process for all chemicals. In Australia, he had worked as a senior regulator with the Queensland government. In Canada, he has worked as a regulator in Newfoundland and Labrador. Dr. Hedges is now based in Ottawa as an occupational hygienist with OHCOW, where he coordinates research as part of the McIntyre Powder Project, MPP, and carries out retrospective exposure reviews to assist with WSIB claims and mentors junior staff. Dr. Hedges is also the international president of Workplace Health Without Borders in a volunteer capacity. And so we are so pleased to welcome Dr. Kevin Hedges, who will reflect on lessons and solutions from Science and Sensibilities as experienced by thousands of workers during the first wave. Hello and welcome, Dr. Hedges.
Hello, Ricky, and thank you very much for the great introduction. Just going to find the presentation here. Okay, great. We're there, I think. Okay, and welcome everybody, and thanks for chiming into this session. And I want to reflect on OHCOW's, the Occupational Health Clinics for Ontario Workers experience during the pandemic. And just reflecting on, our experience collectively, the pandemic, messages coming from China, about Dr. Lu Wenliang, who really was a hero, wasn't he, when you think about it? They called him a whistleblower, but he really raised the alarm, and he was kind of censored and unfortunately passed away. So I think you just think about the start of the pandemic. That's kind of what we remember. And then more just thinking about Can you hear me, Ricky?
Yes, go ahead. Sorry about that. Technical difficulties. You're on now.
That's okay. Just thinking about Dr. Lu Wenliang and the controversy surrounding his kind of communication from China, and also thinking about locally, you know, a controversy around the coronavirus, you know, with regards to droplet and contact exposure. But, you know, really, it's taken some time to come to the point where we can talk about airborne transmission. And I just sort of thought this little puppy there with a muzzle on kind of could possibly reflect what's happened here locally. And if we think about messaging given from the World Health Organization, you know, back in March 28th, we were told that coronavirus is not airborne with this tweet that was sent from the World Health Organization. But we're on the kind of, you know, many years after SARS-1, where the Commission actually talked about the precautionary principle approach being such an important principle to apply, especially important for interventions. But then as time went on, the different papers were generated. So if we think about a very leading paper by Matthew Evans talking about avoiding COVID aerosol guidelines in June the 4th. And then there's this a pivotal paper by Fears et al. In June 2022, who actually was able to prove that, you know, the airborne coronavirus can stay infectious in air for long periods after production through human shedding and airborne transport. And if I can just sort of pay homage to a colleague of mine, John Udick, who's an occupational hygienist with the Occupational Health Clinics for Ontario Workers, who's done an incredible amount of money, incredible amount of work to lobby about the importance of proper personal protective equipment for healthcare workers. And I just want to talk quickly about a letter that I wrote on behalf of Workplace Health Without Borders. So I'm the international president of Workplace Health Without Borders. And so this letter was written to Teresa Tam and Patty Haiju, who's the Minister of Health. And it's an open letter on the Workplace Health Without Borders website. I just want to thank the Board of Directors for helping me write that letter. We actually have a Board of Directors, a number of about 15 now. And so I just, maybe I can just put in a plug. If people on this call would like to find out more about Workplace Health Without Borders, go to a site and you can join. It doesn't cost anything to join. So thinking about Aerosol Generation, Lisa Brossu kindly loaned me these slides. So if you think about somebody coughing, for example, you know, we could think about being exposed through aerosol generating medical procedures, but also just the physical things that we do, like coughing, sneezing, talking. You know, if we were in a gym, you know, breathing hard, then you can actually generate the aerosol. So obviously the person close to you will be exposed to both the droplets and also the airborne particulate matter. But then this is actually dispersed more broadly, more widely. And then so you can see not only is person B going to be exposed, but over time person C is going to be exposed as well. And what that means is that, you know, really need to think clearly about good ventilation, which I'll talk about in a little while. And I've just provided a hyperlink to Professor Lydia Morawska, who's a lead in this area. And she's one of the 239 scientists that wrote a letter to the World Health Organization to talk to them about acknowledging that the coronavirus is airborne. More recently, the Centers for Disease Control and Prevention on their website now have identified airborne transmission as an important route. And you'll see that in this letter, the QP newsletter, October the 6th, there's been a Directive 5, which has been sort of talking about the importance of proper personal protective equipment for healthcare workers as well. So you'll see the nurses there holding up N95s in the pictures, but wearing surgical masks. And they are quite different. They serve a different purpose. So an N95 or better will protect the wearer. So both John Odick and myself, we're fortunate enough to be part of the Best Brains Exchange, organized through the Canadian Institutes of Health Research, which was actually opened by Teresa Tam. And you can actually go to the OHCOW website and you can see the slides from John Odick's presentation, and also a recording to the slides there as well. It was a really important forum to really sort of talk about, you know, the science and I guess kind of communicate, you know, why it is important to think about the airborne transmission route. And then more recently, Teresa Tam, Dr. Teresa Tam has actually acknowledged airborne transmission. And there's also a hyperlink there to Public Health Agency of Canada Declaration, November the 5th, 2020 as well. I took this from the ABC. It's from a network of mine. We sort of share a lot of information. And this is actually an article where a radiographer who got COVID believes that if he was wearing an N95 and a face shield at work, he wouldn't have caught COVID-19. So if you think of the current requirements, typically, you know, with a point of care risk assessment for healthcare workers, the whole focus is on aerosol generating medical procedures, but a radiographer doesn't do AGMPs, but this radiographer still got COVID. And that's why he's saying that if he was wearing an N95, he believes he wouldn't have got COVID. And obviously there is a significant mental health issue. So it's not really only just getting COVID, but it's all of the health, the mental health effects in the background. And I want to now turn you over to a video provided by John Odick. So it's OHCOW's Healthcare and Generic Pandemic Experience Surveys and what they mean to workplace controls, mental health and COVID-19 prevention during the second wave. Over to you.
Thank you for the opportunity to share the results of our surveys. I first of all want to recognize Peter Smith, who did a lot of the statistical analysis, and he works for the Institute of Work and Health. Also, I want to recognize the people who helped out, various health and safety staff reps from healthcare unions and from other unions, both within Ontario and across Canada, and interested academics from both Canada, the US, and Europe. The purpose of the survey was to try to capture the experiences of workers, both healthcare and non-healthcare, during the pandemic in real time. We had a lot of different questions in the survey, but the ones I want to focus on today are the measures of anxiety and depression symptoms, and the adequacy and availability of personal protective equipment and infection control procedures. Here's a graph of the response rates. You can see that the healthcare in blue responses came in beginning of April till the first week of May, and the non-healthcare workers responses came in at the end of April till the middle of May. The anxiety symptoms were from the Generalized Anxiety Disorder Screen, which is 2 questions about nervousness and worry, and it's rated according to this scale from 0 to 3 for each question. And since there's 2 questions, the total score is from 0 to 6. The cutoff for clinical follow-up is a score of 3 or more. Here you see the results. 54.8% of the healthcare sample screened positive for anxiety, and 42% of the non-healthcare sample screened positive for anxiety. Depressive symptoms were similarly structured, 2 questions about interest and feeling down, depressed, and hopeless. The same scale from 0 to 3 for 2 questions for a total score of 0 to 6, and the cutoff is identical to the anxiety of 3 or more. 42.3% of the healthcare sample screened positive for depressive symptoms, whereas in the non-healthcare sample, it was 34.7%. We asked questions about the adequacy and appropriateness of personal protective equipment. If the personal protective equipment was appropriate and adequately supplied, we define that as respondents having their needs met. If it was appropriate but inadequate or inappropriate or not there at all, they were different shades of needs not being met. The list of personal protective equipment for the healthcare workers is listed below, and also for the non-healthcare workers. Here you can see that for healthcare workers, 18% had all of their PPE needs met, and for non-healthcare workers, it was 37%. For infection control procedures for healthcare workers, we had a similar scale. Appropriate and adequately implemented meant that their needs were met, and that was the green category. Appropriate or problems with adequacy and implementation had various shades from yellow to brown. The list for the healthcare infection control procedures is given below. And for the non-healthcare workers, it was a different list of infection control procedures or measures. The perceived adequacy of infection control procedures is provided in this graph, and 16.9% of healthcare worker respondents had 100% of their needs met, whereas in the non-healthcare it was almost 23%. Then we compared the proportion of respondents who screened positive for anxiety by their category of PPE needs met or infection control procedures met. You can see for those who had all their PPE needs met, 43% screened positive for anxiety, whereas for those who had none of their needs met, 61%, and a similar pattern for infection control procedures for the healthcare workers. For depressive symptoms, there was a similar pattern, but not as stark. These were adjusted for various variables so that we could see just the relationship between the infection control procedures, PPE, and the outcome, whether it be depression or anxiety, and the list of items that were controlled or in the analysis is given at the bottom of the slide. For the non-healthcare workers, here you have a breakdown of the responses for both the anxiety and depressive symptoms by where they are working. The blue is working at home remotely. The yellow is working at a workplace, site-based workers, and the black is workers who are unemployed. And you can see that working remotely had a lower rate of people screening positive for anxiety or depression compared to the other 2 categories. When you broke this down according to their needs being met, we see a bit of a different pattern. Working remotely or working at work with all your needs being met was roughly about the same, 34 or 35% people of the respondents screening positive for anxiety, whereas having none of your needs being met at work was associated with 52% respondents screening positive for anxiety, which was even higher than being unemployed, which was 44%. Similar for infection control procedures, it's interesting to note that if you are at work with 100% of your needs being met, only 30% of the respondents screened positive for anxiety, whereas working at home was 35%. Again, you can see the same pattern for not having any needs met and not working at all. So the key messages here are that PPE and infection control procedures and measures are not just about infection control, they are also associated with mental health symptoms. And strengthening and monitoring these programs is important both in healthcare and non-healthcare. Working at a workplace with all your needs being met for infection control is associated with less anxiety than working at home. All this suggests that the ongoing monitoring of mental health of workers is also warranted in this pandemic, not just the infection rates. If you're interested in knowing more about this study, it's been published for the healthcare workers and is available at this link. The non-healthcare worker study is set to be published, I believe, next week or the week after. Thanks for allowing us to share our findings with you. And if you want to get a hold of us, you can contact me at this email address or Peter Smith at his email address. Thank you again.
Okay, if I just want to say a big thank you to John Udick for all the work that you're doing here. And I'm just now going to my next slide here. And this was just shared with me by Val Wolf, who's an executive director at OHCOW. So OHCOW are still looking for people to continue taking the survey. So I've actually provided some hyperlinks here to the survey for healthcare workers and all other workers. And you can see they're in English and in French. And if you go to the OHCOW website, you'll be able to take the surveys through the website as well. And I believe our booth may have those links too. But if we're thinking about the workplace reimagined, and now, the Canadian government has come out and talked about the importance of airborne transmission, then ventilation is very important. And I've provided a hyperlink to a recent article that talks about the importance of ventilation. And there's actually a gym owner, and he's talking about the things that he's put in place to greatly improve the ventilation. But if we think of the workplaces that are going to have the highest level of risk, obviously gymnasiums are going to be quite up there as well. Just to reflect on what OHCOW has been doing. For 30 years, we've been working with workplaces to promote occupational health and prevent occupational disease. But especially since March of this year, we've been looking at literature. We've been curating international research and guidance on SARS CoV-2. We've been particularly focused on advocating for recognition of the risk, control and protection from aerosol particulates. So we've been communicating the evidence and leading practices. And on our website, you'll see there's some hyperlinks. John Udick's been following the requirements for personal protective equipment, and his concerns have been around the downgrading of personal protective equipment, especially respirators. If we think about now coronavirus being airborne, as a minimum, we'd expect there to be an N95. And I'm talking about for non-medical generating procedures or non-medical aerosol generating procedures. we've actually provided a series of webinars. So with part one, looking at the science solutions, we've actually involved world experts to talk about the up-to-date evidence, including Dr. Lindsay Marr, Dr. John Conley, and Dr. Donald Milton. So you can actually go to the website and see them talking about the evidence for airborne transmission. We've also engaged world experts to talk about the hierarchy of prevention and controls, including Lisa Brosseau, Deborah Gold, who was instrumental with the Aerosol Transmissible Disease Standard in California, Professor John Sherry from the Institute of Medicine talking about ventilated headboards, and also Dr. Simon Smith, who's an international expert in respiratory protective equipment. I just want to take this opportunity to really thank Neil McDermott from PSHSA, working closely with me, and also Sandy Jones as well, for co-hosting and co-presenting at applying the hierarchy of control to point of care risk assessment for the protection of healthcare workers, which you can actually see that video on our website as well. And I just thinking about leading experts like John Sherry and the work he's doing looking at ventilated headboards in hospitals. If you have a look at the OHCOW website too, you'll see that there's guidance to tools for every workplace, including a regional risk tool, which I'll show you in a minute, and also a workplace risk management control banding matrix and a ventilation checklist that we've developed. So this is the regional risk tool. Thanks again to John Udick to being the developer and the catalyst, with his family that is, behind this risk tool. Provides a 14-day rolling average by region, and these are the risk bands we use. And there's different recommendations depending on the level of risk. So if I can get you to look at that on our website as well. This is a control banding matrix. We actually use the OSHA risk levels, and we align the OSHA risk levels with the hierarchy of control. And I just want to kind of, it's very busy, you won't be able to see the detail there, but sort of for high risk, just general hospital workers, it's really pointing them down the road of wearing at least an N95. But then for the very high risk, for aerosol generating medical procedures, we're highly recommending that powered air purifying respirators be worn. And I was actually watching an episode of Grey's Anatomy last night, and it was interesting to see healthcare workers walking around in powered air purifying respirators. So it sort of seemed to be the norm in Grey's Anatomy. So I'm just wondering in hospitals in Ontario, how many PAPRs are being used by healthcare workers. And you'll see there's articles being released now about the importance of airborne exposure and also the importance of ventilation in schools. That should really be a priority. So I guess then I'm just going to ask the question, do you know how good your ventilation is wherever you work, whatever your workplace is? And OHCOW have a ventilation checklist that will help you evaluate your own ventilation. This is in English and French. And the very first question is, has the hierarchy of controls been used to implement physical distancing, appropriate engineering, administrative, and personal protective equipment options in that order? And then the second question, there's many questions, this is just the first page. Really, it's about checking in with the person in charge of the day-to-day operation of the HVAC system, which is very important. So you can even print this checklist out, talk to the HVAC people of your building, and then go through it with them. Just the OHCOW's COVID series will continue on November the 27th with more science and solutions, including our in-house experts and guests sharing the latest transmission evidence. And so it's actually Friday, November the 27th, between 1:30 to 3:30. I've just kind of put in an infographic there, and Japan avoided a lockdown by telling everyone to steer clear of the 3 C's. So if you think about closed spaces, crowded places, and close contact settings, And you actually take these three circles representing each of those, and then you overlap them. Then when you've got that piece right in the middle, that's the hot spot. So it's really a good way to communicate what the risk is. So just with the guidance tools we talked about, the regional risk tool, the control banding matrix, and the ventilation checklist, there's some good guidance there for you moving forward. And we're 301. I kind of went through that presentation fairly quickly, but leaves us about 15 minutes for questions. So I'll just stop there, Ricky.
Awesome. Thank you so much, Dr. Hedges. So I just want to let everyone on this session know that some resources have been posted in the chat window of the conference virtual URL. And so you should link to the survey Dr. Hedges referenced and also the website for OHCOW. Now, this will be sort of the last call for questions. If anyone does have any, I would suggest or recommend you post it right now. In the meantime, I'll ask you, Dr. Hedges, maybe a quick question, something we've been asking a lot of our speakers today, and I'd like to get your perspective on it. You know, in light of COVID-19 and all the things that have changed in the world, what would you say is the hidden blessing from the current situation we're in?
Well, right from the get-go, you know, on behalf of Workplace Health Without Borders, with a lot of inspiration from John Erdick, we actually wrote a letter to Patty Hedges and Teresa Tam. And I'm sure it's because of that letter we got an introduction, we got an invite into the Best Brains Exchange, and we were to share what we knew through that forum. And now they've actually turned the corner and they've acknowledged airborne transmission. So I think that's a really pivotal moment. And I think there's an opportunity for everyone on this webinar to really take note of the importance of this and think about their own ventilation. Also, you know, in their own workplace, think about, are there going to be situations where a face covering or a surgical mask isn't going to offer the kind of protection that you know that's warranted here, because a surgical mask won't protect workers from the airborne transmission route. And we're talking about very small particles that can actually go in around the outside of the surgical mask. They're not tight-fitting respirators. So I think it's a pivotal moment in my view.
Thank you very much. All right, just checking the window here. So we have a few questions here. I'll start with one from Leah. Leah asks, why did it take so long for Public Health Canada to say there was spread by aerosol?
I can just give my own viewpoint here, and this is just like listening to other people. You can hear that I'm not from here. I'm from Australia, and I've only lived in Canada for 10 years. But I think firstly, the science is being dominated by public health infection control specialists. And even sitting on the Best Brains Exchange forum, as an occupational hygienist, I felt kind of a bit marginalized. This is our science, you know, we're trained to protect workers in workplaces from hazards. So when it comes to, you know, respiratory protective equipment, you know, looking at the Canadian standard for respiratory protective equipment, we're trained in how to do that. But for some reason, we've been marginalized. And it's really just not a Canadian issue. It's also international. Colleagues of mine, occupational hygiene colleagues of mine in Australia, are also kind of doing the same kind of work to lobby and to influence the influencers, so to speak. But I think it's such an entrenched thing in infection control science, which in my view is quite outdated.
Great, thank you for that question, Leah from McMaster University. And we have another question here from Dhananjay from the University of Waterloo. So the question is there any recommendations on minimum air changes per space based on persons or square footage or use that you could provide to reduce risk? Maybe, for example, what minimum rates should be?
Yeah, it really depends. It's on a case-by-case basis, and it really comes down to occupancy. So the ventilation rate should really be based on the number of people in the room. And recent reading that I've done, what's actually happening in the room? You know, you would think, for example, a gymnasium. You know, obviously you've got to have the physical distancing there, but if a gymnasium were to be open, then the ventilation rate would have to be so much higher. And also, if you think about an ICU in a hospital, the exchange rate there, I think it's like 12 air changes per hour. So it really depends on the actual, the occupancy and the activity and the risk, if that helps. So Ashrae is an organization, it's a North American organization that sets standards for ventilation. And, you know, that's a really good go-to place to find the latest guidance around ventilation and in indoor air places, indoor air spaces across all public and in workplaces as well. Also, if you go to Workplace Health at Borders YouTube channel, you'll see that there's webinars that have been provided through Workplace Health Without Borders. And we had a professor, Dr. Joseph Allen from Harvard, talk about ventilation in schools. So Harvard TH Chan has some really good information around ventilation in schools. I hope that answers the question.
Thank you very much, Dr. Hedges. So for everyone listening, I have put Dr. Hedges' email address in the chat window as well if you do have further questions after the session. For now, this is going to be the conclusion of this afternoon session. So I just want to once again thank you, Dr. Hedges, for sharing.
Sorry, can I just add to the answer for the last question? With Joseph Allen, he was actually recommending 5 to 6 air changes per hour in schools. So obviously, you know, kids are going back to school, highly occupied. So it's really important that schools look closely at their ventilation system. Also, looking at the ventilation in schools and in classrooms, one good way to sort of gauge the indoor air quality is through measuring carbon dioxide. So there's a lot of discussion now about using carbon dioxide as an indicator of indoor air quality. And also, it's very important if you think about recirculated air to make sure that the recirculated air is put through at least a MERV 13 filter. I just wanted to add that last bit, Ricky.
No worries, thank you. It's very useful.